Right, good morning, everyone. I'm Adrian Kwam, one of the ophthalmic anaesthetists from Nottingham. I'm here to talk to you about the Nottingham faster turnover cataract pathway. Just to clarify, when I started this pathway, I was a ophthalmic anesthesia lead, and I'm the head of service for ophthalmology. So I'm kind of cross specialty here. I have no conflict of interest to declare. I can improve your theatre efficiency by 60%. And obviously they thought I was a snake oil salesman, and no one really believed that, but this is actually what I've done. And because this is what happened in our hospital, we were doing 5 cases. The green box is the surgery time, and the red box is not when we're not doing anything in theatre. And because we start late all the time, and we were doing 5 cases, and it takes a long time to change over between theatres. Compare that with Norwich when they're doing 14 cases over the same period, and still manage to have a coffee break in between. But then you notice that the surgery time is a lot shorter, but also the turnover time between theatre is a lot shorter as well. So I went down to find out what they did, and just to clarify another point first. Turnover time, when I talk about turnover time, I'm talking about the time between the last dressing on for the last patient to the start of surgery for the next patient. So it's this long period of time. When people talk about turnover time, they normally talk about the last patient leaving theatre to the next patient entering the anesthetic room. And our turnover time is 20.5 minutes, which is ridiculous, really, because the operation is almost as long as the operation itself. So why be so slow? And this is why. We're running things in series. So we take the last patient out of theatre, we take everything out of theatre so we can clean the theatre properly, and then the scrub nurse will wash her hands and prepare the trolley, and then the next patient can come into theatre, and then the surgeon will then wash her hands, and then we can start the next case. The whole process takes 15 to 20 minutes, which is, as I said, a long time. So coming back to this question again, you might think it's 25 minutes to cook 5 packets of noodles, and you're assuming that you're using 1 saucepan and 1 hob. But if we have 5 saucepans and 5 hobs, then we can do it so we have 5 saucepans and 5 hobs, and then you can do it in 5 minutes. And this is what we should have done. So we split the pathway into three work streams. So for the patient, the last phase can go on, patient leave theatre straight away, then can clean theatre, and then the next one can enter theatre. The surgeon write the notes, wash your hands, and start the next case. But what's happened is that we prepared the trolley well beforehand. Preparing the operating trolley takes normally about up to 10 minutes for the scrub nurse, depending on how experienced the scrub nurse is. And so if you prepare the trolley beforehand, then you can save a lot of time. And we can do all that process in 4 to 8 minutes, which is a big time saving. And the more you can do that, the more time saving you have, and the more cases you can do. There's no one-size-fits-all model. What I'm going to tell you and show you in a minute, you may not be able to replicate exactly. And certainly this is not, what I've said, this is not new. This has been done by a lot of different places where they are set up to do such a thing. And this is what we need really, as I said, is the prep room. We need somewhere to prepare the trolley beforehand. If you haven't got that, you can't be fast, full stop. So we didn't have a prep room in Nottingham, so how do we do that? So what I did was using the anesthetic room as a prep room. A new idea no one's done before. Why does it make sense? Because there's plenty of space. Most cataract surgery are done under topical, so it's just eye drops, so you don't need a space to block the patient. It's right next to theatre, so you can just push a trolley straight through. You don't need it really if you're doing topical anesthesia. Infection control tell you that you can't open the trays in the anesthetic room because it's not clean enough. You need 25 air change to allow a sterile field to be created. So what we did was we bought one of these laminar flow machine, which will give you clean airflow, and it will allow you to open a surgical tray in a sterile condition, and that will satisfy infection control policy. And these machines, actually, you can find these machines in intravitreal injection clinics downstairs in your outpatient clinic, so you may have already have one in your setup. And I was the first one in the country, in UK certainly, to do it this way, and maybe in the world as well. We also bought one of these. These are operating chairs that go from chair position to supine position, and I'm going to show you how we do it. We start the video, please. Excuse me, can you start the video? So for this demonstration, I'm making it a little bit more difficult. I'm doing a block somewhere else for the patient. So this is the end of the operation. We've got a surgeon just coming off and starting to write the notes there. We've got a scrub nurse from last case trying to clean up. We've got a helper that's taking the patient out of theatre. Just going to sit. He's taking his time, still speaking to the patient properly, and he's going to sit the patient up in a minute, and he's going to bring the patient out of theatre. The surgical trays are already been prepared in the anesthetic room with the laminal flow machine, so it's all very clean, as it's all still sterile. And what you may notice also, that no one's rushing. No one's running around working any extra fast, but we still do this, we still complete the turnover in just over 6 minutes in this case, and we could certainly do it a bit faster. So now my colleague is sitting the patient up. The surgeon's writing his notes on the computer, and there's no rush, as I said. Patient is not just chucked out of theatre like you might have expected, to make things go a bit faster. So the block is done in another part of the theatre complex, which is about 30 seconds walk away. And the patient's is being blocked while the last case was happening. So the patient leaves theatre in 1 minute 40 seconds. And then we're just going to wipe everything out, clean the whole theatre, make sure there's nothing from the last patient. And then once the runner is happy, we'll let the scrub nurse come through to the theatre. And now all she needs to do, there's a bit of delay there, but that's all she needs to do now is to set up the phaco machine, and then we're ready for the next case. Now, you can argue that I could have set the patient outside this door so the patient can come straight through. We haven't got room for privacy, so we didn't do that for this patient, for our patient, because it's not nice to set him outside watching everyone go past. So we kept the patient in this place. So what we're waiting for now is from the last patient to come round, who past the corridor there. Now we're going to come down the long corridor back into the theatre, and we can start the next case. Now, this surgeon hasn't done this fast. This is the first time this surgeon did this pathway, so it's not used to how fast we actually work. But you'll see in a minute that we could have, if he was a bit faster, we could have done this turnover in about 4 minutes. We're just coming down the corridor still. And very soon we'll be arriving. As I said, notice nobody is rushing around. So everyone's walking very leisurely. There's no rush no pressure on anyone. If you can make people work faster, but you're only going to make people more stressed. And when people get stressed, they go off sick and not come back to work. You notice those marks on the floor. This is where we park the trolley exactly in the same place every single time. And now the patient is almost ready for theatre. 3.5 minutes. If the surgeon was a bit quicker, we could have done it in 5:44 and 4.5 minutes. So it can be done. If you turn over in 5 minutes, and you take 20 minutes to do a case. In theory, you'll be doing 8 cases and still be quite relaxed about it. And this is what we've done. We're still starting a bit late, but we're doing surgery over this time, but the turnover time is not shorter compared to before. And you can see how that if we reduce the late start, we can probably fit another 2, maybe 3 cases on there. So 11 medium complexity cases, or 11 cases that takes 17, 18 minutes. That's pretty ridiculous, but it can be done. And this is another example of what I've done. So this case, we did 8 cases on this list. We had two surgeons on that day, but if we had done it normal way, this would have taken 4.5 hours. But because we did the faster turnover, and despite one patient who didn't like to go on that chair, and we had to push the whole table back in again, despite that, we wasted a bit of time there. We finished everything in 3.5 hours. We could have done more cases. We can apply the same model for other types of surgery as well. So this is obviously glaucoma surgery. It was done by a trainee and a consultant. The trainee was doing the reformation of AC. For some reason, it took her 21 minutes to do. That's fine. The consultant did the phaco, took 17 minutes. That's fine as well. The bleb needling didn't take very long either, 16 minutes. That's fine. Now, the trainee was being trained, and she was doing the PRESERFLO operation. And because she was training, it took her 64 minutes to do the first case. If we had been doing the normal turnover, by this time, we've got 1 hour left of 1 hour theater time left. Most team would say, we can't do the training because everyone wants to go home early. And then the consultant would be taking over the case, will still finish on time. That is fine. But because we were doing a faster turnover, the turnover time between cases is a lot shorter. It was 1.5 hours left before the end of surgery. The trainee was allowed to do the case, and we still have half an hour at the end of the case. You can argue I can put another cataract on there. It is this good. It does make sense, turning it over theater quickly. And this is, as I said, part of the reason why I'm here is this is recognized internationally in UK. So I won some awards. It's been recognized by the NHS in UK, and I'm trying to promote this across the country in UK and hopefully the world as well. So in summary, you need a prep room. If you haven't got a prep room, you'll never be fast and you'll never be efficient. But if you haven't got one, make one. You can make one very easily with this machine in the anesthetic room, push a trolley through, and you're ready for the next case. There needs to be a paradigm shift. I'm sure a lot of you will be under pressure from your managers saying that you need to do 8 cataracts per hour per session. You need to do 8. I shouldn't be doing that. As I said to you before, what I tell my surgeon now is that if I can turn over theater in 6 minutes, how many cases can you do? Obviously, if it's a shorter case, you can do more. A longer case, you can do less. But still, whatever happens, you'll still be doing more than what you would before. If you improve efficiency, you will naturally do more cases. That's what I keep telling all my managers. It doesn't have to be cataract. It can be anything that's any operation under 45 minutes, you benefit from a faster turnover pathway. Theatre team of any experience and speed can use this pathway. We're splitting pathway into the work stream in parallel, so the scrubness can be very slow. It doesn't matter. He or she can take the time, set up the trolley while the case is happening. If it takes that person 10 minutes to prep the trolley, we'll start a bit earlier. If it takes 5 minutes to prep the trolley, you can start a bit later. But whatever happens, it will still work for them. It will work for everyone, and no one needs to work any faster. And that is a key thing. Your team is the most valuable asset, so make sure you look after them. Because if you stress them, they will just leave. We'll take questions at the end. Thank you very much. Who's next? So, let's get my screen back up again. So next speaker is Alfred Chor on safer modern needle blocks. Alfred is from Australia. Is from Prince Alfred Hospital, Australia. It's not named after him, as I gathered, but he's from Australia. It's good house about blocks. Thank you.
Thank you very much. No. Good morning, everyone. Thank you very much for coming. I want to talk about the needle block. Just to start off, I have no conflict of interest to declare. Now, the eyeballs essentially round, and technically speaking, you can put the needle anywhere and the local anesthetic will go around. And you really can stick the needle in any direction and the block will work. Question is, what is the better way to reduce the incidence of complication and having a safer block? So I'll quickly talk a bit about the anatomy, what needle and what type of blocks we're talking about, what the modern day peribulbar block insertion site is, a bit of the technique and video demonstration, and certain circumstances you need to be careful with. You all know about the eye. I'm not going to make it the same. Retrobulbar block go into the cone, peribulbar block go outside the cone. Now, more importantly, the ciliary ganglion always sit in front. So you got to be careful not to have your needle sticking into the cone and damage the ciliary ganglion. Now, the nerves are inside the cone, but there's also a bunch of nerves on the superior nasal corner that are outside the cone. So if you put the needle in on the infratemporal region as what you normally do, then those three nerves on the top will typically miss or not blocked it as completely as you would. And equally the same if you do a medial temporal block, not all the nerve will be blocked completely either. And therefore, there is an argument of doing two blocks in some cases. So you want a smaller gauge needle. Whether they're sharp or short bevel doesn't make any difference. You don't want a long needle. Now, the long needle will really reach to the back and damage potentially the ciliary ganglion, where the short needle, as I demonstrated yesterday on the workshop, are much safer on the 25 millimeter. And I know people here using 60 millimeter needles, so it's even safer. So that's what you really don't want to do. If you looking at the diagram, you can see using a long needle, a 38 millimeter needle, it will reach potentially the ciliary ganglion, where a 25 millimeter needle doesn't do that. Arterial and venous system, Dr. Chandrakumar mentioned yesterday earlier, draw a line across it. Everything above is messy, don't go above it. Everything below is probably safer. Now, typically we talk about the 2/3, 1/3 junction. It's actually very close to the inferior rectus and inferior oblique muscle. So why don't we move the knee so more to the extreme infratemporal region where there is no muscle and there's lesser chance of muscle injury? That's what I will be emphasizing today. So in the proper eye, that's the safest area in terms of vascularity, and that's the second spot you can do. Typical 1/3, 2/3 junction is on the blue line, and what I'm promoting is moving the needle further away to the extreme infratemporal area. So that's the modern day one, and you can see I always stand outside and I'm coming in from a quite extreme angle, and it's demonstrated on the skull model. That's the position if I were going to do a medial temporal peribulbar block. Now, you want the eye to look straight and not rotating, moving around. That's what I usually do. And by having the eye rotating around, you actually can straighten up the optic nerve and make the nerve more prone to injury. So have the patient looking at what I call neutral gaze, just look straight in front, and that's what I would normally do with my blocks. Stirring of the needle is supposed to be rocking the needle to and from. Now, aggressively, if your needle is already into the eye, that's a bad news. But a gentle rocking of it just to see whether you're in or outside the group, probably not a bad idea before you start the injection. How I would do it, I normally use a 25, 20 millimeter sharp needle. I prefer to use a non-Neurolog syringe, and because I rotate the bevel in line with the marking. Topical, local anesthetic to the eye, clean the eye first, and I always have the bevel facing the group when I do the insertion. And once the needle goes through the skin, I look at the syringe marking to know exactly the angle and the direction of the bevel. I prefer to use a bit of sedation. Usually I use them propofol. The most anxious patient, I give them a midazolam. Eye block, and then personally I just use digital compression. You get used to how much pressure you put on. It's not very scientific. There's other device you can do. In terms of the video one, you can see I come in quite extreme, and I have the patient looking at a neutral gaze. I put in a depth of about 20 millimeter, and when you do the injection, you typically will see the inferior, the lower eyelid thing sort of start swelling up, not the whole eye bulging out like a retrobulbar block. And that's quite typical, and I always test the pressure to see how much volume I want to put in. In Australia, you have all types of patient, and therefore I use digital testing of the eye to see the pressure and adjust the volume accordingly. If I were to do a medial peribulbar block, I tend to have the needle slightly pointing to the nasal side at the initial insertion, and then I straighten it and put it down. I only put the needle in somewhere between 10 to 15 millimeter, and I don't go in too far. You can do them either as a single injection, either way that's fine, and you probably need to put in a bigger volume as a single injection. If you want the 2 injection or you want to do supplementary block, then obviously a smaller injection volume. Various ocular compression device, either using mercury bag, you can use a helium balloon. Things that you got to be careful is if they have a big eye or the eye's recessed back, if they have a sparkle there, the eye doesn't open up properly. That can be a problem, and small children you got to be careful with. Big eyeball, if you stick it in, obviously more likely to prank the eyeball. The bigger eyeball also have the risk of having a staphylomas on the back, and therefore putting a needle deep in, you're likely to perforate the staphylomas and therefore perforate the groove. If you look at the eye, as the eye gets bigger, it's not an even expansion. The AP diameter expands more than the lateral diameter at the equator. Therefore, in a bigger eye, personally, I would just put a subtenon in. If you were to do a needle block, then it's probably safer to do a medial canthal block rather than an infratemporal block. The eye sunken in, if you put the needle in, obviously, again, you're more likely, especially if you tilt the needle, you can perforate the groove. Squirrel buckle, if the needle tip hit the buckle, you can deflect it in. So that can be a real problem. And also it makes the eye more elongated and longer. So you've got to be careful when you do them. Thank you very much. All the complications, I'll leave it to the other speaker to talk about.